Hi, my name is Elizabeth Morrison. I'm a psychologist, an LCSW, and an addictions counselor. And this is Trauma Informed De-Escalation, Part 1. Before we talk about de-escalation prevention and some early intervention, I just wanted to encourage everyone who's listening to this to think about a time where someone that you've been related to might have been an escalated patient. I know that often in clinics, we tend to think of people who get really angry or who are escalated as kind of an other, like an other person, it's a whole nother group of people that does this. And sometimes we might have even been an escalated patient in a particular situation. We might have raised our voice at a receptionist or a call center person. And if not us, probably someone we've been related to. So we can kind of think about this as more of a we, I think, phenomena than than just a group of other people. And this is my brother. He has an addictive disorder and he struggles with his mental health. And twice in our adult life, I have been with him when he was the escalated patient. And I sort of stepped in to sort of help de-escalate him. So often when I am stepping forward to help with a de-escalation in a clinic, um, I often think to myself, how would I want my brother treated? So, of course, there are many different types of escalations. Psychosis is one type. Sometimes, if people are having delusions or audio hallucinations, then they might be talking to themselves or becoming really agitated. That's one type of escalation. Sometimes people can be so fearful and anxious that that is a type of escalation. I remember once in my clinic, there was a receptionist who called me to come into the waiting room because there was a woman pacing back and forth, and she had a baby in her arms and a little toddler. And she was also going in and out of the door of the waiting room as well. And it was really making everybody in the waiting room anxious and the receptionist. That's really an escalation as well, a type of escalation. And then, of course, the one I think we most often think of when we think about escalations is anger. And this is probably the one that we see most in our clinics. And in case you've noticed that there's been an increase, we do know that that's true nationwide, that since about 2021, we have seen an increase in escalations in healthcare settings. So, what we're going to talk about today actually works and is helpful for psychosis, fear, anxiety, or anger. It's helpful with every type of escalation. And in my examples, we're mostly going to talk about anger escalations because it's the most common. So, of course, the reason that the Health Center Association of Nebraska asked me to do this, and the reason that you're probably talking about this in your clinics, is because escalated behaviors cause a lot of problems. Um, they're maybe, I would think, more problematic than many other sort of quality issues that we struggle with in clinics. They really, really take a toll on us as individuals, the patients that we serve, and the systems that we're in. And part of the reason that it's so problematic, anger escalations, is because for many of us and for many of our patients, it stirs up childhood experiences. Not all of us grew up in homes where there was a lot of problematic anger. Many of us did, though, and many of our patients did. And if you grew up in a home where when people got angry, they also got mean, so there was the kind of verbal abuse, or when people got angry, sometimes it led to violence, and it was unpredictable when that anger would lead to violence. Um, if you were in a home where anger never got expressed verbally, but people were sort of punished with silence, and so, sort of ostracized or something, then when somebody walks into the clinic and, starts yelling or swearing or hangs up when they call the call center, it can not just be an unpleasant experience right now that we're experiencing, it can also stir up pain and difficulties in past experiences that we've had with anger. And this is true also of any patient who witnesses this. So if somebody fires up in an exam room and yells at a medical assistant, and the patient in the exam room next door can hear that, it can stir up their own difficulties that they had as a child with anger. So it really hurts us. For us, I mean staff that is sort of the recipient of the anger. It hurts us. It hurts patients who are witnesses, and it hurts staff who witness it as well, even if they're not a part of it. It can re-traumatize. So those who've had trauma in childhood that's related to anger, anger and violence, anger and verbal abuse, um, it can re-traumatize, and then it causes really deep mistrust in the clinic. So if all of the patients and the staff that see an escalation happening, depending on how it was handled, if it wasn't handled in a skillful way, or if it wasn't talked about after it happened, then patients start to mistrust the clinic. They start to think about the clinic as not a safe place. And that can happen for staff too. Sometimes if we don't handle an escalation well and nobody in our clinic follows up or talks to us about it, we can start distrusting that our organization cares about us or that they can handle escalations well. So I want to say one thing about equity, because verbal abuse escalations are not equally distributed. I know this from my experience in working in community health centers for many years. I'm sure you listening to this know this, and we know from the research that it is not equally distributed. And the people who are the recipient of the highest percentage of escalations and anger are receptionists and our call center folks. That doesn't mean that others don't experience this. Of course, clinic managers get their share. We know that physicians and other licensed providers get their share as well. And I think it's really important that it's acknowledged that it is really our receptionists and call centers who get the great majority of the abuse. In the research, 80% of receptionists and call center folks have been the recipient of verbal abuse. In my experience, it's 100%. But just to speak to the research, it says 80%, which is far and above what other staff get. There are some risk factors for aggressive behaviors. When patients have chronic pain or substance use disorders, that can be a risk factor for aggressive or angry behaviors. And I'm going to talk about that a little more in a minute. Protective empathy, meaning if the patient has a child with them that they're advocating for, or if they're advocating for a partner or a family member, they're going to be more apt to get angry or have aggressive behaviors when they don't feel like their needs are being met. That's just like the mama bear phenomenon, that in fact, the time I've been angriest in healthcare settings was really around when I had one of my family members with me that I felt like was being treated poorly. When people don't feel heard, when they feel ignored, then that's a risk factor for angry behaviors. And if patients feel humiliated or disrespected, so if they feel there's been a wound to their dignity. So I'll just give you some examples of that. When patients are in the waiting room and they've waited for an hour and a half and they see other people going before them and no one has come to talk to them, they start to feel ignored, disrespected, unimportant, and it starts to feel a bit like a humiliation. And so by the time they get to the front, even though we know why other people are being called before them because they're seeing different providers, the fact that they were ignored for so long and they feel less important than these other people who are going in, it's a risk factor for them then yelling. Not feeling heard. I'm sure most of us have interacted with angry patients that repeat themselves, and that's because they don't feel heard. So we're going to talk about what we can do about that to nip that sort of in the bud. But that's why people escalate, and that's why they start to repeat themselves when they feel like they're not being heard. And then I want to go back to chronic pain and substance use disorders, because often when I share that this is a risk factor for angry behaviors, people say, well, of course it is. People don't get the pain meds that they want. Or of course it is. They're under the influence. No wonder. And that's not actually why it's a risk factor. The reason it's a risk factor is because chronic pain and substance use disorders or addictive disorders are the two most highly stigmatized conditions in primary care. So folks who have chronic pain or addictive disorders or both have been mistreated in primary care multiple times before the time that they escalate. And so maybe it wasn't in our clinics, maybe we do a good job with them, but certainly in other systems, they have been stigmatized, they've been treated poorly. People have rolled their eyebrows around, rolled their eyes around them, sort of like, oh, another drug seeker, They feel that. So there's a lot of wounds. So when they come into our system, they're hyper vigilant, kind of looking for not feeling heard, looking for a wound to dignity because it's accumulation of what they felt in other systems. So they're more at risk to escalate. So this probably sounds like a simple statement. The goal of de-escalation is always only emotional and physical safety for everyone. That is the only goal, is safety. That's it. There is no other goal. And that includes emotional safety. The reason this is not as simple as it sounds, like it sounds super basic and simple. Like, of course, that's our, of course, that's the goal. Of course, that's what we're trying to do when we're, de-escalating someone. The reason it's not as simple as it sounds is because often when someone gets angry at us or in our systems, our tendency is often to do other things. For example, sometimes we want to be right. So sometimes if someone is really angry because they're telling us like it's wrong that we won't release their records, they own their records and we should be releasing them. And we know that we're not allowed to release all of them because some of them would be like a secondary disclosure, which HIPAA doesn't permit. Sometimes we want to get in there and say, well, no, that's not actually accurate. You don't actually own all of your chart. Like we're not, we want to explain, we want to be right. Or if someone gets really mad and says, this is the fourth time you've rescheduled my appointment, we can say, well, I can see that's not actually the case. You've only been rescheduled twice. So if we just even think about in our personal lives, when someone gets mad at us, often we want to explain to them why they shouldn't be mad at us, why we're right about this thing. And that escalates people more. So even though it is a tendency that most of us have, we want to make sure we do not do that in a de-escalation because our only goal is emotional and physical safety. It is not being right. Sometimes we ignore people who are getting angry, and we'll talk more about why that's very, very problematic. It does not make anger go away, and it often increases it. Disagreement, which is another version of being right, even if we are right, I want to be really clear about that because often we are right. Even when we are right, we do not want to disagree when someone is angry. That is a huge problem and causes people to be angrier. We can disagree later. We can call them after. We can talk to our supervisor. We can call the patient in. We can explain everything later, but not in the moment. And it is not the time to explain rules. When someone is getting angry, it is not the time to say, well, you did sign that, opioid contract. So you should have understood that we would have to discontinue you, if your analysis was positive for amphetamines, or it's not the time to explain rules because people are escalated and it makes people angrier. And remember, we only have one goal, which is emotional and physical safety. And it is not the time to tell somebody, if you continue, we might have to not treat you anymore. You might have to be kicked out. We might have to discharge you. We don't want to impose any consequences while someone's angry. We might impose them later. But even if we think about like, if you have kids and we think about our kids and when, if our kid is really mad and it's not the time to be like, you're going to be grounded for the next month, we might have to ground them, but it's not the time to say that because it makes people angrier and that's not our goal. So we want to just hold on to all of our tendencies to do these things and avoid it. Successful de-escalation is always based on a relationship. So it's always based on, even if we don't know the person who's escalating, it's always based on how successful we can be in humanizing them, humanizing ourselves, and sort of developing a relationship with them in that moment. And it really, really depends on how well we can manage ourselves. So if we get angry when people get angry at us, that is a big problem in de-escalation because it makes people angrier. So we really want to take a deep breath and see if we can manage our own anger. And on that note, it's really important that we know ourselves. How do we respond to anger? What do we know about ourselves just as people? So while I'm talking about this, I would just ask everyone to kind of reflect on what they know about themselves. What do you know about your history, your own history with anger? What anger was like in your family, how you typically responded to anger when you were young. What do you know about your history of anger as an adult, your own anger and how you respond to other people's anger? What do you know about your personality? Just people's personalities are just different, in terms of how we respond to anger. If we get super scared and we shut down, if we cry, if we get angry back and want to kind of puff up, like some of that stuff is just personality stuff. And then, of course, what do we know about our skills? Meaning, how much practice have we had in de-escalation in our adult lives? Do we have the skill of kind of de-escalation that might be natural, or is that our tendency? Are we kind of a peacemaker or a mediator? Are we able to stay calm in the face of anger? So if we think about our history, our personality, and our skills, what do we know about ourselves? And the reason that it's so important to assess ourselves is because not everyone should be de-escalating. So what I'd like everyone to sort of say to themselves right now is think about your team. Who's your group? Who's your team at work? Who's your, is it your group of receptionists that you work with? Is it the treatment team? Is it your clinic? What do you know about your group? And once you know about everybody else in your group, what can you share about yourself? Now, you don't have to share about your childhood history. Absolutely. That's not what we're asking anybody to do. But to share with people, I get angry when people get angry at me. So I am not the best person to take the point when a person is escalating. Another person in your team might say, I freeze and I just start crying and I kind of can't do anything and I just want to get away. And it's really good for us all to know that when we're on the same team. And you might have three other people who say, I feel okay. I feel like I'm decent at this. I feel like I can take, point when somebody has escalated. So what I'm encouraging everyone to do is talk to your team, talk to the group that you work with, and make sure that you know everybody else's sort of self-assessment about how they are with escalations and that you share with them, because not everybody should respond to an escalation. If you're a person who gets mad when someone gets angry, you should stay away from escalations. You should back off and let somebody else in your group take point. So I'm going to talk about prevention, and I don't want to talk about it in a way that like people feel blamed. Like, gosh, if you prevented this, if you did better, you could have prevented this escalation. That's not always the case. And there are a lot of prevention strategies that we can engage to lower the number of escalations that happen. One of them is our environment. So on the left is a picture of a real place where I live, a real community health center that I went in, and it was just filled with these terrible signs that are essentially yelling. We call them command signs, and they show authority over people. It shows a power and control relationship. And if your waiting room is covered with these signs, you're going to have a higher level of escalations because they're insulting. And anytime people feel like they're being shouted at, or that somebody has power over them or wants to have power over them, then they're going to be more apt to escalate. And that's also true of like glass partitions, um, torn furniture, dirty waiting rooms, dirty exam rooms, anything that shows that we don't care, like the environment shows that we don't care, is going to make for higher escalations. Picture on the left is a real place where I live that has a very, very low budget and was able to create a nice, clean, comfortable waiting room. They have very few escalations. This isn't the only thing that affects escalations, but the environment really does impact the percentage of escalations. Eye contact. When people first walk into the clinic, of course, this doesn't count for telephone, but when we make eye contact with people, it lowers escalations. When we smile at people, it lowers escalations. When we greet people with a hello instead of a do you have an appointment, when we say, buenos dias, buenas tardes, good afternoon, instead of saying sign in and have a seat, when we use people's names and when we use our own names. So these four things are considered prevention strategies. And that means if people walk in, we look at them, we smile at them, and we say, hi, welcome. And we say, I'm Elizabeth, Mr. Gomez, I'm glad you're here. Do you have an appointment? Before we launch into the business of why they're there, that people are less likely to escalate when we have done these things with them. Connecting talk is a prevention strategy for escalations. If we joke with somebody on the phone, if we say, I can't believe you made it here, is it still raining out there? That kind of like small talk. When we compliment people, when we say, oh, your baby's so cute. When we say, oh man, I totally appreciate you being early. When we say, hey, can I get you some water? When we say, gosh, do you want to like shake off your jacket? Do you want to wait in your car? It's going to be really long today. I'll text you when it's time. Any kind of connecting talk means that even if that person waits an hour in the waiting room, even if that person doesn't get the medicine that they were hoping for in the exam room, when we have done these things with people, they will be less likely an hour later to escalate on us because we have showed ourselves as human and we have humanized, we have let them know that we know they're human. That's what connecting talk does. So I'm sure that many of you might be thinking like about this person on your team who is so good at those things that I just mentioned. There's usually people on the team that are so good at this. And I would just encourage you to say to them after you finish listening to this, like go to them and say thank you, because they've probably prevented quite a few escalations in your system. Team conversations are a prevention, like we talked about. If you have conversations with your team before escalations about your skills and about what the plan is when somebody is escalating, then it is a prevention strategy for escalations. Lastly, I want to talk about, this isn't prevention, but it also is before early intervention, before we see anger in someone. This is pre-escalation. So this means when we can see that people are unhappy about something and they're not yet angry, we can do a series of things that can sort of head off them getting angry. Yes, they're unhappy, but we can keep them from getting angry. One of them is misuse names. Just like the prevention strategy, if we see that somebody is unhappy, we can go directly to them and say, or on the phone, we can make sure that we say their name. We can apologize as quickly as we can. I'm so sorry nobody called you back. As soon as someone indicates that they're unhappy about something, very quickly, even if it's not our fault, even if it's not the clinic's fault, we can say, I'm sorry. This is really important during a period of unhappiness with a patient to keep them from getting more angry. We can reflect their feelings. I hear you. Gosh, it is frustrating to not have people call you back. And then we can offer a solution, not before we apologize, not before we reflect feelings. We want to do it after we do those things. We want to offer a solution, any type of solution that we can. And then we want to normalize. Oh yeah, anybody would be, anybody would feel that way. Oh yeah, I wouldn't like that either if somebody didn't call me back. We want to normalize their unhappiness. So these 5 things take practice. The ones in red, 2 and 5, typically take a lot of practice. We don't, many of us don't feel like apologizing. Maybe we don't want to apologize. Normalizing, sometimes we don't want to do that. So these take a lot of discipline and practice. That's why they're in red. And they're very powerful strategies to use in pre-escalation, which is just when people are unhappy before they've become angry. So that was trauma-informed de-escalation part 1. So if you would like to hear trauma-informed de-escalation part 2, which covers early and middle stage intervention when people are already angry, you can listen to that video next. On this same website for the Health Center Association of Nebraska, there is also a series of written resources like de-escalation tips, and this is where the other video is located as well.